Okay, welcome everyone to the University of New Mexico Law and Mental Health Didactic Series. This is a series hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences, along with the New Mexico Behavioral Health Services Division. Thank you, all of you that are coming here to join us today. I'm Anthony Perillo, the Forensic Psychology Training Director in the Division of Forensic Behavioral Sciences here at the University of New Mexico. For our talk today, if you have any questions for our presenter, make sure you enter them in the Q&A box anytime you feel comfortable. Just know that we do hold the questions until the end. We always try to get to as many as we can, but it's not possible oftentimes to get to all of them, so just forgive us if we don't get to yours. If you are pursuing continuing medical education credits, there will be a sign-in sheet that will be posted in the chat box very shortly. And for those of you that are pursuing APA continuing education credits, that link will be posted around the end of the talk. You'll need to make sure you open that link before you close the webinar, and make sure you save your certificate after you complete the survey, because we don't have access to those certificates after the fact. The PowerPoint slides and a recording link for this will be available sometime later this week. And as a heads up for next week's talk in the series, we'll have Dr. Ofer Zur, who will be discussing ethical and moral junctions in forensic mental health services. But let's get back to this week. I'm very excited to introduce you to today's speaker, who will be discussing responding to persons with special needs in forensic settings. This is Dr. Robin Wilson. Dr. Robin Wilson is a board-certified clinical psychologist with almost 40 years experience in sexual violence prevention. He's worked in academic, clinical, correctional, and community settings, and has published and presented widely on topics related to social psychopathology. His current interests lie in promoting evidence-based methods of assessment, treatment, and risk management for persons who have sexually offended, with a particular concentration on ensuring responsive services for persons with special needs. Robin also maintains a private consulting and clinical psychology practice in Sarasota, Florida, and is an adjunct assistant clinical professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University in Hamilton, Ontario, Canada. Dr. Wilson, Robin, on behalf of the University of New Mexico, thank you again for joining this series. We're very excited to have you, and are honored to have you sharing your expertise and useful knowledge with us today. I will go ahead and throw it over to you.
All right, Tony, thank you very much for those kind words. I am very happy to be part of your series. It's always fun to be able to talk with people, although it'd be lovely to be in a room with all of you, seeing all your bright, shiny faces. But this is the way the world is, I suppose, these days. A lot of things online, and that's what we're doing today. A couple of things just to note. Every talk, workshop, webinar that I do comes with what I refer to as a lifetime guarantee, which means that if you have questions, and I know there will be an opportunity to ask some questions within the time we have today, but for anybody who perhaps doesn't get their question answered, or who for some reason thinks of something after the fact, my email address is here on the screen, rjwphd@gmail.com. Feel free to shoot me an email if you have any questions or concerns or comments or anything that's in some way related to what we're going to talk about this afternoon, and I'll be more than happy to respond to those. I typically do so fairly quickly, and I take that whole lifetime guarantee thing pretty seriously. So by all means, if you have questions or anything after the fact, shoot me an email and I'll be happy to respond to that. So we're going to be talking about ensuring responsive options for persons with special needs in forensic settings. I'm going to try to keep the bulk of my commentary towards, sort of special needs individuals, which I'll define in a moment. Going to keep that to sort of broadly forensic settings, but as Anthony noted, most of my work has been in the sexual violence prevention realm. So I may tend to use examples of kind of sexual violence, although I think for the most part, most of my commentary in those areas will be fairly easily translatable to other domains within the forensic work that we do. So here's my bio, which Anthony already talked about. The CE stuff, I think you've already seen that as well. There's no financial arrangement that is related to the content of this talk today. The views are mine. They're not of the University of New Mexico or McMaster University for that matter, which is my home base. This is all my own stuff. Anything that isn't mine, I think I have appropriately referenced. The learning objectives: through involvement in this workshop, participants will be able to listen, explain the 3 principles of the R&R framework. Number 2, through involvement in this workshop, participants will critically assess common barriers to responsive service delivery for persons with special needs. And 3, through involvement in this workshop, participants will be encouraged to think creatively when developing intervention regimes for persons with special needs. So, pretty clearly, when we do the work we do, increasingly the world is a smaller place. There's a lot of movement, across borders. We have a lot of immigrants here in the United States. Most of our partner nations are in the same boat. Certainly I am an immigrant to the United States, having moved here from Canada in 2007. There are many other types of cultures, some of them, quite disparate between Canada and the US. Not an awful lot of differences, although some of them are fairly key. But I think when we speak about persons with various, special needs profiles, I think that's a culture as well. I mean, certainly disability is a culture. And within the risk-need responsivity framework that we're going to talk about today, culture is a potent responsivity factor and always needs to be thought about when we're, trying to craft interventions or other sorts of services that we're going to apply to people. So this presentation is going to highlight the need to be responsive to all elements of the client's current and future functioning, just to make sure that we're being fair, I guess. So because I work in the sexual violence field, often my mother says you need to get a job that doesn't involve penises, or I've been working with those perverts too long, is what I think my mother once said. So here's just a little joke for you. You can't really say happiness without saying penis. So who are we talking about? So in the context of this presentation, special needs is a relatively broad category that includes many different clinical presentations, or sometimes a combination thereof. So we're going to have some folks who have a brain injury. We've got some people who are on the autism spectrum, including what we used to call Asperger's syndrome. Fetal alcohol spectrum disorders definitely will be part of what we're talking about. Intellectual development disorder and borderline intellectual functioning, which I'll probably refer to as intellectual disability if I do so. Some instances where a person has a severe mental illness that impairs their cognitive abilities, and then others with impaired cognitive ability due to a variety of reasons. One of those, something that I've noticed, and I think others have as well, that institutionalization can result in a kind of acquired cognitive atrophy. It's almost like people go into prison or into a long-term institutional setting somewhat better off cognitively than they might become over years and years of perhaps having less than adequate agency or opportunity to engage in kind of critical thinking. If you think about most institutional settings, not a lot of opportunity to express your own personal choices. Pretty much everything is chosen for you, including when the lights go on and off, what you eat, when you eat, with whom you eat. So it's certainly been my observation in the institutional settings that I've worked in that there have been a number of people who seem to not really live up to their IQ, so to speak. So when we talk about special needs in crime, it's tragically well known that persons with mental health difficulties increasingly being found in institutional settings. Once upon a time, those institutions used to be state hospitals and those sorts of environments. The deinstitutionalization movement of some 50 to 70 years ago certainly moved a lot of people out of those settings, but unfortunately, both here in the United States and in my home country of Canada, we experienced the same sort of difficulties in that when people moved out of the institution back out into the community, the funding for those services didn't necessarily follow them. the sort of end result is that unfortunately, in a lot of cases, prisons have become the new psych hospitals. And certainly people working within those correctional settings have had to adapt to a somewhat different population that includes a lot more clinically, clinically prejudiced individuals. So it's reasonable to assume, I think also, that some of those people with special needs are not adequately identified by the courts, sometimes on purpose, unfortunately. The simple end result of it is that those people who look different or who have special needs are unfortunately often more likely to be incarcerated, and incarcerated for longer than average. So here's what a judge in Canada observed around special needs and sexual offending. Herein lies the problem relating to the commission of sexual offenses. Having a mature body beyond his intellect, he has urges for sexual gratification, which leads to impulsiveness and unpremeditated behavior without using caution and with risk-taking. This is followed by non-comprehension that the behavior was inappropriate. And this is often the challenge we face. So let's talk a little bit about effective interventions. So most of you, I'm sure, will know about the nothing works agenda versus the what works agenda. Way back in the 1970s, some fairly influential research published that suggested that the interventions we were offering to people in correctional environments weren't having any measurable effect on outcome. Ultimately, those findings were largely retracted, although as it often turns out to be, usually that retraction doesn't get nearly as much notice as the inflammatory statement at the beginning. And unfortunately, we still have, some 50 years later or so, an awful lot of kind of administrative staff who still might ask, why are we spending all that money on treatment? Doesn't the research show that it doesn't work? Or even worse, doesn't the research show that it potentially makes people worse? In response to that nothing works research thread, lots of smart people decided, well, that hasn't been my observation. Let's see if we can kind of contradict that. Here are just a small handful of the many very large-scale meta-analyses that were done, basically looking at what happens when we offer interventions to people in institutional settings because of bad behavior. And so we have the Smith, Goggin, Jondro from Canada, the Eos, Miller, and Drake from the Washington State Institute for Public Policy, the Lipsey and Cullen. And all of these, I'm sure there are overlapping studies in all of these, but we're looking at some fairly large scale studies. I think that the findings here are, for all intents and purposes, probably an answered question. And all of these meta-analyses arrived at the same conclusion: punishment alone will not reduce bad behavior. This is a quote from the Smith et al. Paper. We are confident that no matter how many studies are subsequently found, sanction studies will not produce results indicative of even modest suppression effects or results remotely approximating outcomes reported for certain types of treatment programs. Ain't that a mouthful? Here's just a little insight, and I'm sure I've got tons of other psychologists online with me today. So speaking as one who knows many, this is clearly a sentence written by a psychologist. It's one sentence with 2 commas and an awful lot of really, really big words. If we as a field could learn how to do anything, I would say, let's be a little more judicious with our words, and let's be a little clearer in our meaning. Because essentially this 6 lines of words basically says punishment alone will not reduce bad behavior. And maybe we should learn how to say it as simply as that. So I think this is an answered question. I honestly don't believe we need very much research on this. It's pretty clear that people who just go to prison go to prison. They don't necessarily learn very much, and there's certainly lots of research that would suggest that they come out maybe a little bit worse off than they went in. If we think of prison as a deep freeze, think of that effect as kind of like a little bit of freeze or burn. So clearly we have to do something with them, but what is it that we're going to do with them? In terms of the risk factors, Bonta and Andrews, or Andrews and Bonta, whichever order you want to put them in, did a lot of great research as part of the What Works movement. And in their, sort of kind of groundbreaking research in the 1980s leading into the 90s that led to the publishing of the Psychology of Criminal Conduct, which is an awesome book, and I certainly recommend it to all of you who don't already have a copy. Andrews and Bonta came up with the big 4 predictors of being involved in crime: antisocial behavior, personality structure, values and attitudes, and antisocial associations. Added to those were 4 additional risk factors that comprise the so-called central 8 risk domains: family and marital factors, poor school and work performance, few leisure or recreational activities, and the omnipresent effects of alcohol and drugs. With respect to sexual violence, which is my sweet spot, my area where I've been working for the last nearly 40 years, there are 2 overarching risk domains that are pertinent in that domain. The degree to which the individual has sexually deviant interests or preferences, and the degree to which the individual has a fundamentally antisocial personality orientation, which kind of makes some sense given the Andrews and Bonta Big 4. These 2 overarching factors may be present to sort of differing degrees, but a strong presentation on both elements is likely indicative of significant risk. Those people who are quite sexually deviant and also at the same time quite antisocial are the sort of people who are going to give us all a lot of trouble. So in terms of the R&R principles, and I don't want to be terribly exhaustive on this because I'm sure I'm not the first person to identify these, but Bonta and Andrews, looking at an awful lot of data, looking at an awful lot of variables, basically came down to it and said, hey, if programs have these 3 attributes, they're probably more likely than not to be helpful. And the risk principle, very simply, who do we target? And we want to focus our efforts on the people who pose the greatest risk. Research is pretty clear: when you mismatch the level of risk with the level of service provision, that's when we experience problems. And it's not just when we under-intervene with the higher risk guys, it's also true when we over-intervene with the lower risk folks. On the old adage, if it ain't broke, don't fix it. The need principle, equally simple: figure out what it is that's causing this person to be at odds with the law and focus on that. While there may be lots of other targets that we might want to think about, those are things we can look at later. Right now, our goal is get this person out of the, out of that correctional vortex of in trouble, in prison, out of prison, back in trouble, back in prison, so on and so forth. That great big, kind of merry-go-round. So we need to focus precisely on the areas of risk that are identified as, leading the person into criminal conduct. The last principle, which is my favorite, and I think all in all, probably the most important part of the R&R framework, is the principle of responsivity. And this basically tells us that there are better ways and not so better ways to intervene with people. I'm going to have lots of comments about this, so I'm not going to exhaust it right now. But simply put, we need to meet our clients where they are. Figure out, what their level of investment is in the process of becoming more law-abiding. What are some of the barriers that might get in the way of that? And are there personal attributes that we need to take into consideration if we're going to make sure to do the best we can? When it comes to the responsivity principle, I'm often caused to ask, do we even know what this is? Certainly there's been lots that's been written about it. I've read most of that literature. I think I have a pretty good grasp on what the responsivity principle is. And I think most of my colleagues probably have a pretty good grasp too, but sometimes I honestly wonder, and I'm not trying to be flippant or a jerk about this, but a big part of my job is around program evaluation, going into various programs and sort of having a look under the hood to see if there are areas that that are going well that we want to support, areas that are almost going well that we want to encourage, and areas that are maybe not going as well as they could, well, we might want to make some changes. And I've had great fortune to, to interact with a number of different programs across Canada and the US and other parts of the world. And I've come to be somewhat suspicious whenever someone says their program adheres to R&R, and then they specifically say, oh yeah, absolutely, we definitely take, responsivity into account. And then, I have a closer look at what's going on, and I start to wonder, not really, maybe not. Or do they really understand what this is? And I think more often than not, the issues are around, are we providing appropriate accommodations to people with special needs? Certainly, in line with the Americans, with what the Americans with Disabilities Act says, or if you're in some other country, I'm sure you have the same sort of kind of statutes or other guidelines around how do we look after the folks who maybe are the square pegs that won't fit in the round hole. So speaking a bit about assessment, my previous assumption that you were a little bit off has been totally cleared up now that I realize you're just Canadian. This is a cartoon. A little bit of kind of self-deprecation never hurts, right? So many of the difficulties that our clients with special needs and behavior problems experience, and I certainly don't mean to suggest that this list is all that different from what we see in a large number of people who are receiving service within any of the kind of forensic environments that I'm sure the large number of you folks work in. But each of these is going to have a special element to it depending on what the aspects are of the individual's special needs, or the way that they've lived their lives, or what sort of kind of adaptive skill level they may have. So looking at how do they speak with others, how do they get their own personal messages across, are they able to receive those messages from others, can they live at home, right? And we find that often, there are a large number of them are not able to do so. How much interface do they have with the broader community? Sometimes that can be quite, limited. Sometimes, depending on risk, it may be limited on purpose. What capacity to self-direct do they have? If they've been able to engage in any academic experiences, what have those experiences been like? Sexuality is a big piece for me, obviously, working in the sexual violence field. But I'll go out on a limb and say that I think the state of sex education for children is terrible, both here in the United States and certainly in Canada, lots of other places in the world. We sort of feel this need to protect children from sexuality, when I think that's maybe not the best way to go about things. And I'm not entirely, I'm entirely trying to stay away from the political element of it. And I know that this is a big part, certainly, of some of the discourse here in the United States at the moment. But I think we need to be better about preparing children for the sexuality that will absolutely be a part of their life as they grow older. Self-care, big issue for people with special needs. Social skills, how they interact with others, clearly a big area. Health and safety is something that maybe we need to step in at times. And leisure and work, having joyful activities for our clients to engage in, always a major concern. And of course, leisure and work, one of those central 8 risk factors, right? So here's a fellow, Dave Hingsberger, was a great influence on me. Dave was an absolute challenge for all people with various disabilities. David worked a lot in the sexual violence realm in Canada, very well known in that country. I think less known in the United States, but not for any good reason I can think of. Dave was the sort of person who bent over backwards in every circumstance to make sure that the client's experience of whatever programming or intervention or life opportunity they were in was something that was going to aim them in the right direction. And the right direction would be having the best possible life with the greatest possible opportunities. Dave died 2 or 3 years ago, and he is greatly missed in our field. Dave is known for a lot of things, and I'll talk a little bit more about Dave towards the end. But one of the things that Dave raised with this was this construct of so-called counterfeit deviance. Now, the empirical literature hasn't necessarily been particularly kind to the counterfeit deviance construct, but I think practically, when we look at behaviors engaged in by people with special needs, I think using an applied behavioral analytic approach is often quite helpful, because I think sometimes it's not quite as clear whether the issue is around the individual's intents or the means by which they were trying to achieve those intents. So is it the goal that's the problem, or is it the means by which they're trying to achieve the goal that's the problem? And you know, what Dave was trying to say is that in his observation, there were some times when people with a special needs profile engaged in behavior that looked deviant in some way, but might not be deviant in the same way as someone, you know, who didn't have a special needs profile when you look at the circumstances. And, you know, certainly anybody who wants to contact me offline by email, you know, to look at some of the work that Dave did in this area, I'd be more than happy to share that stuff, or you can certainly, you know, you can certainly Google Scholar it. On the topic of applied behavioral analysis, I don't pretend to understand this well, although, you know, I've got my name as an author on a textbook, you know, having to do with ABA. And, you know, in the process of actually helping to write the book, I've got a much better understanding of it. But, you know, I think all in all, having some understanding of what it was that the individual was trying to achieve, and then looking at some of the issues that may sort of pop up or be prominent on that pathway from goal to, you know, actually reaching the goal or meeting the goal, or perhaps not because something went astray. I think generally speaking, we certainly don't want to exclude inappropriate behavior in a person with special needs, but I think it's really important to acknowledge that exploring sexual violence and other aggression or other difficulties that bring our clients in contact with the law requires a different approach. And the ABA approach to understanding misbehavior in special needs clients is certainly gaining favor. I'd say 10 years ago, I might not have even known what a board certified behavioral analyst was, or, you know, the so-called BCBAs. They are much more prominent in the special needs realm now. And in fact, many of the programs that I evaluate, I encourage them to hire someone who is who's a board certified behavioral analyst, because they bring a unique skill set to the table. And, you know, I know there's this at times sort of artificial, you know, kind of butting heads between psychology and the, you know, and the BCBAs. I don't think there's any really good reason for that. I think we, you know, we both bring important aspects to the table. This is from a book that I published with one of my colleagues. I should say none of the books that I may refer to today are those that I get any financial reward from. All of the proceeds go back into the clinic, or they go to scholarships for students who want to work in this area. So you know, there's no financial arrangement here. This and I'd be happy to send this book to anybody. If anybody wants a copy of this book by PDF, shoot me an email and I'll be happy to send you a copy. Basically, this outing journal sort of template here is an opportunity for clients to prepare for going out, you know, out into the general community, and to prepare for what sort of things they might encounter. Will there be any risks? What's your plan? Do you know where you're going? Do you know what, you know, how would you respond to any situation that included, you know, a high risk kind of element? You know, how are you going to use your self-regulation techniques? In one of the clinics I work in, we call those SRTs. The guys know what that means, and you know, it's just a cute little acronym for them. And then after they come back, you know, just a kind of debrief. How did it go? Did you follow your safety plan? Did you have to use any of those strategies? If yes, which ones? And then we get them to identify whether the outing was overall positive or perhaps had some negative elements to it. Then we get them to sign off on it. And I think this is a good way for them just to be thoughtful about their experiences when they start to go back out, back out into the community. In terms of formal risk assessment, most of us are certainly aware of the not so recent influx of actuarial risk assessment instruments, things like the static 99R in the sexual domain, or tools like the LSIR, probably the most commonly used risk need assessment tool on the planet. And basically, we want to look at risk factors in two domains: those historical ones on the old adage, best predictor of future behavior is past behavior. There's certainly a lot of truth to that, but we know that as the individual gets further and further away from when the history was actually created, that sometimes we need to look at, what possible changes have occurred. Has the person grown up? Have they had the opportunity to go to treatment or to some other programming? Did they just, the simple passage of time is actually a pretty decent desistance factor. And if you engaged in all your bad behavior, when you were in your mid-20s and you're now in your mid-40s, I think it's a very reasonable question to ask whether or not something has changed in the interim. So we want to take a look at those dynamic risk variables as well, those things that can change, personality constructs, patterns of behavior, aspects of overall lifestyle management. All those sort of things I think are really important to consider. So, those static actuarial tools or those dynamic risk tools, we're going to look at a lot of different types of risk factors, depending on which area the individual has had some problems. There are, of course, lots of structured professional judgment tools as well that help guide us in focusing on those empirically derived risk factors, so we don't fall into the old, habit of basically sort of pulling on our chins and going, I think he's high risk, or I think he's low risk or moderate risk, which, unfortunately, the literature hasn't been kind to that sort of unstructured clinical judgment process. So let's talk a bit about treatment and supervision. So how do we ensure rights in a culture of risk while managing risk in a culture of rights, without making our clients batty and without losing our own minds in the process? And this can be a very difficult tightrope to walk, because we certainly want to make sure that all individuals have an opportunity to learn from their mistakes and to become better people. I think that's at the core of what we ultimately want to be doing with respect to all of the various kind of correctional interventions or kind of forensic work that we do. We ultimately want to identify risk and to figure out a way how to manage it in the most sensible manner. And sensible, I guess, is a real big word when it comes to this, because there's an awful lot of really inventive things that we've come up with as a society that's intended to manage risk, but I don't think necessarily manages risk very well, and certainly often doesn't manage risk very well in consideration of what sort of human service or kind of general humanitarian rights that that individuals have. Certainly in Canada, perhaps to a somewhat lesser degree here in the United States, but I think moving in the right direction, is this belief that we can't simply just throw the same things at our special needs clients that we throw at our ordinary clients, or our so-called neurotypical, or I don't know, non-disabled clients. There is a much greater push to make sure that things are actually culturally relevant, as I spoke about way back at the beginning. And certainly the Americans with Disabilities Act is really clear, and those folks don't take prisoners. If you get sued by the ADA, and if you're doing anything wrong, you're going to get caught, you're going to get sanctioned. And personally, my belief is that if we know there's something we could be doing better, why don't we just do it better in the first place? And I know that's a little Pollyanna, but honestly, I think that what's the point of doing all that research and getting all those great results if we don't do our very best to put that stuff into practice? And I know I'm not the only person who feels this way. I'm sure that, at least a substantial proportion of the 450 some odd people who are on today with me, you folks feel the same way. We're agents of change. Balanced self-determined lifestyle is my favorite phrase. I don't think I've published a paper since the 1980s that doesn't include this phrase somewhere. I love it. I learned it in a life skills coach training program back in the 1990s. Just like a little 3-course, kind of college certificate. But it's really had an enormous effect on me. And I think, when we think about a balanced self-determined lifestyle, for those of you who are familiar with the strength-based types of approaches we're using with clients these days, as embodied in the so-called Good Lives model that we use with many of our kind of sexual violence folks. A balanced self-determined lifestyle, that's a real big mouthful in 3.5 words. And I think as concerned practitioners, as people involved in this field, our goal is to assist all our clients in basically getting to that point. I think honestly, we all should have that same goal. I mean, I've been striving for a balanced self-determined lifestyle since I heard the term. I don't pretend to be doing a particularly good job of it, but it's always in the back of my mind. And what we mean by this is balance. There are so many things about life that contribute to the richness of it. And we really do need to give each of those areas a little bit of time. We need to work a little, we need to play a little. We need some time on our own, we need some time with others. We need some time, expressing intimacy. Sometimes we need, some time to express our sexual intimacy. We need to be spiritual, or, at least consider our place in the cosmos, or whatever it may be. There's a wide variety of different components of a balanced lifestyle that I think a lot of us maybe strive to work towards, but I think ultimately this is usually a work in process over a lifetime. Self-determined is the other really important bit here. Making your own decisions and knowing that the decisions you're making are decent ones. So I put an asterisk here, within reason and always with safety in mind. And this is specifically regarding our special needs folks. Sometimes we need to employ a little bit of guidance when it comes to that self-determined element. So we definitely know that contemporary research says that if you're leading a good life, that's largely inconsistent with continued engagement in antisocial behavior. Brings us to Bill Marshall. Bill Marshall is, for all intents and purposes, the great-grandfather of sexual violence interventions. I doubt you could read a single paper about interventions with people who've sexually offended and not see at least one reference to Bill Marshall. And Bill basically says, if you want to do a decent job with your clients, you need to be warm, empathic, rewarding, and also directive. And the problem is that many people think they have these qualities, but they actually don't. This takes a lot of work, right? It means that we have to stop equating the individual's behavior with the individual. That we need to remember that if we want people to be better, we have to treat them as if they're capable of being better. That we really do need to, as I said, meet people where they are. This is a lot about being responsive to the individuals with whom you work. And I know at times people look at the warm, empathic, rewarding and think, well, these guys have done some serious harm when it comes to sexual offending. Women, children, and other vulnerable people have been harmed. We definitely need to be cautious about this. And I don't disagree. And that's where the D comes in. We're not saying just be, blindly nice to everybody you work with. Clearly, there needs to be goals. Clearly, there needs to be a framework. And, if you can be sort of appropriately directive while always trying to maintain warmth and empathy and, encouragement, this is the better way to do things. I'm always mindful, one of my good colleagues, David Prescott, always cites a certain paper, and I don't remember what it is offhand, and I'm sure I'll get the stat wrong. but he says that this paper says that 83% of therapists think they're better than 83% of therapists, which obviously can't be true. So back to the responsivity principle. So if we want to intervene, well, we need to make some modifications. We need to accommodate the special need that our client brings to the table. Often it means that the materials we use need to be presented in a manner that's simplified without being overly simple, concrete, redundant. I think redundancy and the construct of overlearning is really important with this population. So frequent review of the topics covered is important, as well as having sufficient time for practice for people to, put it into their, into their life and to see how it works out. Given the increasing diversity of our clients, obviously I spoke to this before, but we need to be culturally relevant. We learned the hard way that we need to consider clients from a 360-degree perspective, look at the whole individual, and ultimately the vast majority of our clients are going to go back to the community, and we always have to have that focus in mind. So when it comes to kind of release planning for people who are institutionalized, that release planning process needs to begin as soon as they arrive in the institutional setting. Forward thinking is a really, really important element of helping people to develop that balanced and self-determined lifestyle. Even though you may have a number of years to serve on a sentence, or you may be, indeterminately sent to a hospital setting, at some point, the opportunity to go back to the community will be there, and having made good plans towards that is a really critically important part of being able to do this well. Here's a cute cartoon for you. I've used this for years. I taught Stripe how to whistle. I don't hear him whistling. I said I taught him. I didn't say he learned it. Ultimately, our goal is to make sure that the services that we provide actually lead to something. We can't have, all that money and all that time and all that effort put into, the sorts of interventions that may not ultimately get us very much bang for our buck. So in modifying those interventions, reduce reliance on those verbal materials, increase use of visuals and monitoring, increase practice, sex education for those people who have engaged in some sexually inappropriate behavior, or where they're having difficulties in that domain for people who are not specifically having any difficulties with sexual offending, increase supervision and structure where appropriate, active teaching, explicit instruction, lots of time to talk about things. If medication is necessary, let's make sure we get them on the right medication. And rules and consequences, I think, are very important. We want to make sure that our clients with special needs understand that when they engage in behavior that's harmful or hurtful to others, that there are consequences that come with that. I'm not saying we should throw them all in jail or put them all in prison. In fact, I might actually be inclined to say the opposite, but there needs to be a consequence. There needs to be something that happens as a result of the issues that the client has brought to the table. This is a feelings thermometer from a workbook some of my clients and I put together. And basically the idea is to give them both aspects, give them the words so they can read it if they want to, but they also get a sense just from the colors. Generally in our culture, something green is good, something red, not so much. And at the bottom here, we have cool and calm. And as people experience things that cause them to have an emotional response, sometimes they get a little hotter to the point where they may actually start to lose control of their behavior. We also want them to think about what's going on in their body. Do they feel anxious? Are the hairs on their arms sticking up? Is their heart, palpitating? Are their palms sweaty? Those sorts of things. And also to think about what some of the intervention stuff might be that they might employ. I think we also have to think about, the literature with respect to sort of crime and punishment and the interventions that we engage in. Most of the literature says that cognitive behavioral stuff is probably going to give us the most bang for our buck. But with this population, we're upfront identifying that there are some cognitive challenges. So often I think we need to consider the extent to which the special need that our client demonstrates may interfere with that individual's ability to function in that broader cognitive realm. This is where bringing in some of that behavioral focus and we're using ABA and having a BCBA, or as I said, a board certified behavioral analyst on staff or someone you can refer to, becomes really, really helpful. We need a structured plan. We use a lot of data collection. So we want to, successively approximate success for our clients, knowing that they may start off pretty poorly, but with assistance, with an opportunity to get some direction, to practice new ways of doing things, that ultimately we want them to gain a better understanding of what it is they're looking to achieve and what are perhaps some better ways to do that. I think we also need to always keep in mind the kind of prevention element as well. The recent literature, and when I say recent, I mean the last 10, 15 years or so, in our domain at least, there's been an influx of research and discussion around the influence of adverse childhood experiences. I'm old enough and been in this field long enough to remember days when we never allowed people who had sexually offended to talk about their own histories of having been a victim. That, it was almost as if being a perpetrator sort of prevents you from ever being able to discuss what may have happened to you when you were a child. We know that's a fool's errand at this point, and we can point to tons and tons of very high quality research. The CDC is really close on the, really clear on this as well. If bad things happen to you when you're a kid, the chances you're going to experience some difficulties as an adult are highly increased. Where those bad things are, sort of explicitly abusive, whether it's physical, emotional, sexual, otherwise, that those are sometimes very influential factors for people to experience difficulties, sometimes leading to incarceration. We know that people with special needs have often become offenders, but when we look at their histories, there's an awful lot of abuse, an awful lot of kind of victimization. The unfortunate reality is that in the ocean of offending, there are sharks and there are smaller fish, and the smaller fish get taken advantage of, or the fish that don't have the same sort of kind of protective instincts or those sorts of things, and those are often our special needs clients. Dave Hingsberger, who I mentioned before, said that about 90% of people with an intellectual disability have experienced some element of being a victim. Sobsey in '94 said 4.5 times as much as their peers without disabilities. So lots of potential issues here. We also know that many of the traits or scenarios that increase risk for being a victim might, for engaging in victimization, may also have a feedback loop to being a victim yourself. Here's a cartoon, the bluebird of happiness long absent from his life. Ned is visited by the chicken of depression. Challenge. So I'm going to focus a little bit on the sexuality element here. It's as I said, it's my sweet spot. I want to talk about promoting healthy sexuality while maintaining safety. My good friend, Dr. Blasingame from California, says individuals with intellectual disabilities may lack certain social and relationship skills. However, they all have the same desire for social comfort, personal relationships, and meeting of sexual needs in appropriate ways. I think this applies to all special needs folks, whether they're folks with sexual violence histories or not. Here are some great videos that were published by Dave Hingsberger some years ago. I don't know the status of his publishing house at the moment. I know that his partner has maintained some of this, but these are really very helpful. These are instructional videos, basically. And the one on the left, it's called Fingertips, is an explicit video that shows a female person with a disability how to masturbate. Love the titles here. The one in the middle, Handmade Love, same sort of thing. And again, these are very, very explicit, but very in a sort of very appropriate at the same time. They sort of start off with, you're feeling sexually interested, you're thinking about masturbating. These are all the things you need to do. And then it shows the process, with the physical aspects of it. how you do it safely, how you clean up after yourself, make sure you have, some privacy, all that sort of stuff. Very, very helpful sorts of instructional videos we use with many of our intellectually disabled clients. Undercover Dick, how do you use a condom, right? Which seems simple. Well, I mean, it seems simple at this point in our life, perhaps, but thinking back to our teenage years or, first time of using a condom, sort of look at it and do I unwrap it first? Do I unroll it first? Or do I, what's the process? Undercover Dick tells you exactly how to do that. What if the sexual practices of the person in care are unusual or abnormal, right? To what extent are we going to intervene or kind of direct them? Unusual and abnormal doesn't necessarily mean problematic, although potentially could be. Here are 6 of my favorites, and I'll tell you a few very quick stories here. So I had one barely verbal client who had a penchant for putting things in his anus. Anything longer than it was wide was highly likely to go up his butt. On one occasion, he put one of those wooden rulers with the sort of that metal edge on it up his anus, and a 7-centimeter laceration required, I think, 2 transfusions and a couple of hours of surgery. Once he was healed up, pretty clearly we didn't want that to happen again, so we gave him a butt plug. Seemed like the smartest thing to do at the time. Center top, those are actually diapers, as you probably recognize. With some of our autism spectrum guys, they like the feel of them. And I've had many a client say that, they like to masturbate with them. I'm always a little cautious because I think diapers are a really good proxy for children. And, given that I work largely with people who have sexual behavior problems, we want to make sure that we're not encouraging them to fantasize about children during the masturbatory process. So be really cautious with this. If there's no issue with respect to children and they can achieve the same end using, using an adult diaper, then perhaps we'd consider that. Top right is called a fleshlight, and it looks like a fleshlight, but it has a vagina on the end. There are some you can buy with anuses or other things. And basically, this is a masturbatory aid. We know that many of our special needs clients also have some physical limitations. Sometimes they have a hard time closing their hand enough to actually masturbate in an effective way. A fleshlight is a good way to help out with that. Bottom left, that is indeed chocolate Jello pudding. We had one client who did a lot of fecal smearing, was actually at times eating it as well. I'm sure all of you just cringed a little bit. Very difficult, client presentation, always trying to be creative. I said, what if we gave him chocolate pudding? Would that be a sufficient proxy that he would, mess around with that, and doesn't smell as bad, it's easier to clean up, and certainly doesn't get the same response if you eat it. At the time, we had to stop because the client gained I think 20 pounds. And it never occurred to me at the time, all those years in school, Ph.D. be gone, never occurred to me that Jello comes in sugarless as well. So we could have given him the calorie-free version. In the center, that's a blow-up doll. One of our clients was getting close to a point where he might be able to leave the group home. And he said, I've never slept with a person. I don't know what it's like. And, I'm thinking about getting a girlfriend and maybe trying to, build some sort of relationship. How will I ever know what it's like to sleep with someone? They said, can I get a blow-up doll? So we took him to the sex shop, or Linda's Lovelace and Lingerie, the more upscale sex shop, and told him, pick out the one you want. And so he chose this one. And he, sort of blew her up, slept with her in the bed, kept her in the closet during the daytime. After a while, we noticed that he wasn't sleeping with the doll anymore. We sort of asked him, hey, what's up with, I don't remember what the name was he gave her. He says, she makes weird noises at night. So seemed like a good idea at the time. Dr. Frankenfurter in the bottom right there, in this highly charged, sort of discussion of trans issues that we have these days, As far as I'm concerned, if your client wants to dress up in drag or women's clothing or whatever, if he's not hurting anybody, if he's not interfering with anyone else's life, if it's not clinically contraindicated, why should we care? Right? I'm a strong believer in the state has no place in the bedrooms of the nation. It's a famous quote from Canada. You can Google it if you like. But, basically the idea is if you get up in the morning, feed your children, send them off to school, go to work, pay your taxes, you're a decent citizen, and none of the practices you engage in are harmful to others, or if there is any harm, that it's consensual harm and there are code words and whatever else. If you want to have a little fun and be a little kinky, I probably don't care, and I'm not entirely sure why the rest of us should care that much. So there's just a few cute examples of how I've tried to be creative in my approaches to some of the difficulties that our clients with unusual sexual interests might pose. So an incredibly brief summary. Tips to maximize case management efficacy: follow the R&R principles, especially the responsivity principle. I'll say it again when we get to the end of this slide. Be data-driven and remember those data when setting policy and practice guidelines. Evidence-based decision making, not decision-based evidence making. Absolutely, we need to collaborate in our work and in our advocacy. We're stronger together. We have a very big voice that I think we need to use more often. And for God's sake, as psychologists, can we be a little more judicious with our words and speak to some of the lay persons? I'm mindful of the fact that most of the work we do gets published in relatively obscure journals that even most of us don't read. I think ultimately the key is to take all of that great knowledge and expertise that we have amassed and make it more accessible to ordinary people. Involve the community at large. This is exactly the message I'm trying to say. They can help, and in fact, we can't manage the risk posed by many of the people we work with without their help. Engaging in knowledge transfer, incredibly important. It's part of what we're doing today, and my hat's off to to Anthony and his school for providing this series of talks. Great stuff. I'm happy to be part of it. And responsivity. Try to apply this to virtually every aspect of your life, right? In the engagement you have with others, not just your clients, but your families, your friends, your coworkers. I think just always being considerate and knowledgeable about the sort of idiosyncrasies that others bring to the table is really critically important. So I referred to a number of papers and books and studies in this talk. Here's a pretty decent reference list. I may have missed a couple. Anything I did miss that people want the actual proper reference, by all means, shoot me an email. I'm happy to do that. This book at the bottom here, the Wilson and Burns, I'm happy to send that to anybody who wants it. It's no longer under active copyright, so I can send you the PDF without drawing much problem from Safer Society. There are my contact information. My email address is there. Remember the Wilson Lifetime Guarantee. More than happy to talk with any of you at any point by email. If there are questions, concerns, comments, or if you just want to, explore something a little further, shoot me an email and I'm happy to respond. Okay, and there is the evaluation link or the QR code that all of you will need to, or at least some of you will need to access in order to answer the survey. Okay, thank you for your time. Anthony, that's it for me. Look at that, right dead on 2 o'clock.
Right on the top of the hour. Thank you so much, Robin, for that very informative talk. We have questions trickling in. We are at the top of the hour, so you are, of course, free to exit the webinar. Robin is, graciously has agreed to stay on for a little bit to answer some questions. If you have any additional questions, you can enter them in the chat. We'll get to a couple of them. Somebody did ask if you believe some respondents may be too cognitively impaired to ever comprehend or ingrain sex offense treatment enough to reduce their level of risk. They add, when doing evaluations, I'll see respondents with cognitive limitations who appear to go year after year without making changes. And it makes me wonder how much is the result of cognitive limitations and if it's fair to expect any more.
Yeah, I think absolutely. more often than not, I think we're aiming ourselves at the folks with borderline intellectual functioning, the people who are mildly disabled, maybe some of the higher functioning, moderate folks. But the more profound the person's disability, the more difficulty I think that we're going to have. Often with those sorts of folks, it's less about treatment and more about lifestyle management. Just making sure that they're in a safe environment. I'm just looking at one of the question and answer things. Somebody mentioned something about the term Asperger. Now, I absolutely 100% ignorance here. Had absolutely no idea that there was any relationship between Asperger and anything to do with Nazi Germany. From this day forward, shall never use the term again. Thank you for the instruction. I very much appreciate it.
Absolutely, and thank you for that that follow up there of that context. Are there particular circumstances where special needs might factor into decisions regarding whether to do treatments in an individual versus group format in correctional settings?
Yeah, I think sometimes this is determined to a certain degree by what the density is of persons with special needs and how well they might fit together as a group. Because it's likely that there are going to be different levels of functioning, different levels of kind of adaptive skill. We don't want to impede the progress of some people while kind of accommodating the progress of others. Sometimes individual care may actually be the only way that we can do that. Ideally, I think a mix of both is probably quite helpful. I think the overall intent is that we want to make sure that everybody's getting the best they can get. Sometimes the individual's location in a prison or in a psych hospital or maybe one of the civil commitment centers for those people who have been deemed to be sexually dangerous, sexually violent, whatever the terminology is. Sometimes you don't have that kind of critical mass to build an actual stream. But I think where it's possible, we should be doing that. We definitely don't want to mix in the special needs folks with the non-special needs folks if we don't have to. We want to make sure that there's an actual adapted curriculum, not just using the same one, I don't know, slower and louder. Slower and louder is not an actual accommodation. I think we actually need to be a little more thoughtful about that. So yeah, individual if you have to, but I think group is useful because they feed off each other, right? And there's a lot of group learning experience that can be quite helpful.
Absolutely. Thank you for that. Someone asked if you could share any other resources that are more visual or handout format for sexual education that is appropriate for those with special needs.
Yeah, so in the one book that I said I'd send you a copy, at the back of it, there is a very decent appendix. I'm not going to make any comments about what we wrote at the beginning, but I'll tell you, one of the most helpful bits of that book is a 15 to 20 page section that lists by the sort of need area, all of the resources that we were aware of at the time with the name of the instrument or the tool or the package, with its publisher, often with address, phone number, website, email contact addresses. Some of that stuff is free. Some of that stuff you'll have to pay for. To the extent that there are different types of sheets that you might use, things you could print out and use. They are included in in the book that I referred to, and you're more than, I'm more than happy to have you make photocopies of those or adapt them to your own need. So yeah, absolutely. Anybody who wants to get in contact with me, more than happy to share that stuff. Contact info slide back up. Yeah, so do that. Yeah, rjwphd@gmail.com, or you know what? Put Robin Wilson sex into Google, and I think I'm like the first 10 pages of hits. But you have to put the sex there because there are other more famous Robin Wilsons than me. But yeah, I mean, 10 pages of hits makes my mom really proud.
Fair enough. Yes, so that is Dr. Wilson's contact information there. As he said, feel free to contact him, whether it's for resources or follow-up questions that you have about this material. Again, Robin, thank you so much for joining this series. It's really helpful to think about these things and the customization. I've long thought about that R&R approach and the whole idea of responsivity being, it's the most wishy-washy element when we talk about what does that actually mean, and putting it into practice. So it's really good to hear about ways that we could do that with a particular group of individuals.
It's a big challenge for all of us, and I think that's really the way forward. That we have to do our interventions with our clients, not to them. And I think, we learned that lesson the hard way.
With not to, indeed. That wraps up this week's Law and Mental Health series. We hope to see you next week when Dr. Ofer Zur will be discussing ethical and moral junctions in forensic mental health practice. Thank you so much again, Dr. Robin Wilson. Good to see you. And until next time, we hope to see you again and have a fantastic rest of your week.